Virginia University in USA. Dr. Helmi is considered as an expert in the management of endocrinological disorders and hypertension. دكتور حلمي is شريك في العيادة منذ بدايات، فهو طبعا صاحب المؤتمر زي however, Dr. Helmi will give us an idea about the approach to the cases who have incidental renal or adrenal, because it is written as renal. It's an adrenal masses. He will give us an approach about how to manage these cases. Welcome, Dr. Helmi.
Thank you very much. Thank you. Good morning. It's really a pleasure to be here. I would like first to thank the IADA organizers and the meeting organizers, in particular the board and Dr. د.حلمي. Today I'm going to discuss a very important, becoming more common problem in clinical practice. And as you are diabetologists, endocrinologists, you are going to be seeing more and more of this problem, which is practically what to do with patients with incidentally discovered adrenal mass. This is becoming common because if you think about it, there is about 40 million CT scans are done every year worldwide, 40 million. And this number is going to be increased by about 4% each year. So you can imagine among these 40 million CT scans, you are going to be seeing thousands of individuals with incidentally discovered adrenal mass. So let me share with you one of my patients that I have seen recently. This patient, 55 years old, was evaluated for back pain. She described weight gain about 30 kilograms over the last 5 years. Recently diagnosed with diabetes, hemoglobin A1C was 7.8%. She was not receiving any medications for that. She also recently developed hypertension, and she is being treated with two agents, lisinopril and amlodipine, without really good control. So she is getting into the stage where you may think of adding a third agent, which put her in resistant or difficult to treat hypertension. For the last 2 years, she also suffered from osteoporosis, and she was treated only with calcium and vitamin D supplement. On physical exam, she was obese with BMI about 41.3 kilogram per square meter. Blood pressure was elevated, and she had no features of Cushing syndrome. For evaluation of her back pain, she underwent a CT scan, abdominal CT scan, that demonstrated 2.2 centimeter lipid-rich, and I will get back to this point later on, based on the Hounsfield lipid-rich adenoma, and the right adrenal gland was normal. This is practically her left adrenal adenoma where the arrow is showing. The adrenal incidentalomas are a problem of aging. If you look into individuals less than 18 years of age, less than 1% of these group of individuals will present with incidentalomas. However, by age of 65, 7% of individuals will have these incidentalomas. 7%, that's a lot. And it's equally seen in women and men, and up to 95% of these adenomas are benign. Because this problem is common, the current guidelines recommends that you don't need to worry about any incidentally discovered adrenal adenoma of less than 1 centimeter in diameter, unless there is an evidence of a syndrome, such as Cushing, primary aldosteronism, pheochromocytoma, and so on. So less than 1 centimeter without clinical presentation of a syndrome, you don't have to worry about it. So there are two key questions you need to ask when you see these incidentalomas. First one is it functional tumor, meaning that does it produce any hormones, or non-functional? And the second one, is it benign or malignant? Obviously, it makes a huge difference in the way you are going to manage these individuals if it's a malignant tumor, obviously. In general, you need to recognize that imaging, CT scans, MRIs, are not good in determining the etiology of these incidentalomas. So when the radiologist sent to you a report, the radiologist really cannot determine from just looking into the image if this is functional tumor or not. The radiologist may suggest some characteristics that may point toward adrenal carcinomas or variety of metastatic tumors to the adrenal glands. In addition, not all the tumors that are functional produce manifestations, meaning that they produce subclinical picture. We see a lot of patients with adrenal adenomas that produce cortisol. They don't present with Cushing manifestations, similar to my patients. No Cushing manifestations at all in this patient. In addition, it's very important to realize that any patients presenting with adrenal incidentaloma, 3 diseases you have to rule out. The first one, you have to rule out if this adenoma is producing cortisol, what we call mild autonomous cortisol secretion. The new term now is called MAX. So you may get used to the term MAX because in the old days we used to call it subclinical Cushing. Now it's called MAX. The second disease is pheochromocytoma, and the third disease is primary aldosteronism. These 3 diseases must be evaluated in every patient with adrenal incidentaloma that exceeds 1 centimeter in diameter. One of the helpful issues or factors that could eliminate one of the diseases, the 3 diseases that I mentioned, is looking into the CT Hounsfield units. What's the CT Hounsfield units? It compares the density of the mass to water. The low density means it's closer to water density. The high density, it means that it's not lipid rich. So low density, lipid rich, such as in MAX, primary aldosteronism. High density, such as in pheochromocytoma, adrenal cortical carcinomas, metastatic tumors to the adrenal gland, or 30% of benign adenomas are present with lipid-poor adenomas. One of the things that I found very, very helpful to rule out pheochromocytoma even without measuring catecholamines is to look into the Hounsfields. There have never been a description of pheochromocytoma with Hounsfield less than 10. So if you get a CT scan, ask the radiologist to give you the Hounsfield. If the Hounsfield's less than 10, that excludes pheochromocytoma. For benign adrenal cortical adenomas, 88% discovered incidentally. As I mentioned, it's very common. The median size of the tumor between 1.5 to 2.5 centimeters. 98% of these tumors, the diameter is less than 4 centimeters. About 15% of these tumors present as bilateral adenomas and usually part of a syndrome. The Hounsfields, because these are rich in lipids, the Hounsfields usually less than 10%. 70% of these tumors present with Hounsfields less than 10, while 30%, those are the benign, poor lipid content in this adenoma. 30% may present with Hounsfield more than 10. And again, 30 to 50% of these benign adenomas produce cortisol, what we call MAX. So it's very important to be careful in evaluating these individuals. So MAX, what's called the mild autonomous cortisol secretion, is the most functional adrenal adenoma. It's independent of ACTH, does not dependent of ACTH. It's usually associated with no symptoms of Cushing syndrome. And it's associated with higher incidence of diabetes, hypertension, obesity, dyslipidemias, osteoporosis, osteopenia. So it's very important disease that contributes to a lot of metabolic cardiovascular problems. The gold standard for diagnosing MAX is to do overnight 1 milligram dexamethasone suppression test. It's a very simple test, actually. You give the patient one tablet of dexamethasone, 1 milligram, at 11 o'clock at night. In the morning at 8 o'clock, the patient comes back and you check AM cortisol and ACTH, and you check also the dexamethasone level in the blood. The criteria, you look into cortisol levels in the circulation. If it's less than 1.8 microgram per deciliter, this means that the patient passed. If it's more than 1.8, it's more toward MAX. And the surgical and the treatment is surgical. So the benefits of removing MAX by surgery, and usually laparoscopic surgery, is to improve on diabetes, hypertension, dyslipidemia, and obesity. The pheochromocytoma is a big topic, so I'm going to skim through it, but the best way to diagnose pheochromocytoma is to do plasma metanephrin. You can do it at any time of the day. It's a very good test, very sensitive test. If you cannot do that, I should caution 24-hour urine metanephrin does not usually incidentally found adenomas, does not usually lead to the diagnosis. So be careful with the 24-hour urine, unless the patient has manifestation of Cushing. And treatment is surgical. In primary aldosteronism, usually we screen by checking renin and aldosterone. Renin should be suppressed less than 1, and aldosterone should be increased more than 10 nanogram per DL. And when you need to confirm the diagnosis of primary aldosteronism, you do a saline suppression test, which practically you measure aldosterone and then give 2 liters of normal saline, 0.9% sodium chloride over 4 hours, and then check aldosterone, and aldosterone should be less than 6 in normal individuals, but more than 6 suggests primary aldosteronism. Treatment obviously is surgical. Adrenal cortical carcinomas, time will not allow me to discuss it, so I'm going to skip this one, and let me just give you the current recommendations. For benign tumors, adrenal tumors that are not producing anything, the European Society of Endocrinology recommend hormonal evaluation every year for 5 years, while the American side recommend hormonal evaluation every 5 years, but also radiologic evaluation, CT scans, 6 months, and then 1 year and 2 years, and then stop that. All right? Back to my patient that I presented earlier. My patient had a overnight 1 milligram dexamethasone suppression test. AM cortisol was 2.9, so greater than 1.8, suggests that my patient has MAX. And indeed, this patient underwent surgical removal of this adrenal mass, and hypertension actually disappeared, diabetes reversed, osteoporosis improved to osteopenia, and patient lost some weight. That's all for today. Thank you very much.
Thank you, Professor Helmi, for this, as usual, very eminent presentation. You passed through the steps of managing any